And good morning, everyone. I'm very glad to see Dr. Proctor for the first time in the past 10 years, and he looks just the same. And welcome to the Trauma Teleconference. I'm Dr. Supparerk Prichayudh from Bangkok, Thailand. And today I have an interesting case to share with you guys. This is a 19-year-old female patient. She suffered a motorcycle crash with a car 30 minutes prior to admission to the community hospital. Primary survey done at the first hospital. She was initially alert, awake, and she was talking. She had left chest tenderness and equal breath sound with normal respiration. Circulatory-wise, she was hemodynamically stable. She had soft abdomen and negative fat, and she had deformed left thigh. Neurologically, she was intact, and she moved all extremities, and no back wound, normal rectal exam on exposure. The first hospital did two films initially. They did the left femur film, which revealed a fracture of the shaft femur and normal pelvic X-ray. I called back to the first hospital, and they said that they didn't even get the chest X-ray, even though the patient had tenderness on the left chest, because she looked okay initially. So the first hospital admitted the patient for observation, and they consulted the orthopedic surgeon, and they planned for elective internal fixation of the fractured femur. 3 hours later, after the admission, the patient became dyspneic. They did the primary survey again. She had a patent airway, but she became more somnolent at that time. She was tachypneic with a respiratory rate of 38 and saturation was 73. They gave the patient oxygen mask with bag, and the saturation went up to 87. She had a decreased left breath sound and increasing subcutaneous emphysema along the left chest wall. Circulation, her blood pressure was 105/60 and pulse rate was 150. And she had no active bleeding at that time. They did the repeat fast exam, which was negative again. And she was E4, V2, M5 on GCS. So this is the X-ray, the chest X-ray after the patient became dyspneic. And they sent the patient for the CT scan too. At that time, the patient had normal CT scan of the brain. And they did the CT chest on this patient. They found some fractures of the spine as shown here. She had left pneumothorax with pneumomedicinem with subacute emphysema. And she had multiple rib fractures on the right and more on the left side with a severe bilateral lung contusion. And she had fracture of the left scapula. So my first question to the group is, what should we do at this point? Valeria, could you please moderate for me?
Of course, Dr. Supa. Dr. Antrak, like that?
Yeah, so, and she's still in the other hospital, I believe. Is that right? Still in the other hospital. I gather that's a yes. Anyway, so she needs a chest tube on the left side, and look at the output. Looks like there's no hemothorax, but a large pneumothorax. And in addition, I would be concerned about injury to the airway or esophagus from blunt trauma, and she'd need to be evaluated for that. But initially, once the chest tube gets inserted, if she has a non-air leak that doesn't slow down and the lung doesn't fully expand, that would be more consistent with damage to the a leak in the airway. And you know, at some point she would need to be treated to transferred to Dr. Supa's center. But that would be where we would start. Look for this a source of injury to the air-bearing structures of the mediastinum.
Thank you, Dr. Antrak. Dr. Kasim, Portland, your comment, please.
Good morning. So, anytime a patient has a scapular injury, the amount of trauma that needs to break the scapula is quite significant. In other words, it's massive. And not to do a chest X-ray initially is a very big mistake in this case. Be as it may, she has two contributing factors here, or perhaps even more. Well, let's look at the chest. She has multiple rib fractures, pneumothorax. Obviously, she has contused lung. Anytime you have contused lung, and if you pour in fluid on top of that, that lung is going to leak. That was shown by a surgeon from San Antonio many, many years ago. Second contributing factor that I would also consider in this case would be a femur fracture. A long bone fracture like that sometimes gives rise to fat embolism. And that can happen rather quickly as well. And this seems to have happened rather quickly. So that may play a part in the genesis of this patient's illness. So she has a left pneumothorax. Obviously, Dr. Antrak is correct. I will put a chest tube in. And on the right side, I'm not sure whether I would deploy a chest tube there as well, but I would definitely keep that in mind that I may have to put a chest tube on the right side for a latent pneumothorax that's not shown up at this moment. I would limit my fluid infusion to this patient. Any fluid you will give, 3/4 of them will leak out into the lung and will give you this type of chest X-ray and respiratory problem. Pneumomediastinum is very concerning, and you have to rule out esophageal injury, tracheal injury. So I'm hoping that when they intubated the patient, they probably have looked at the trachea and determined there's nothing there. But be aware that she may have a blunt injury to the thoracic esophagus. So in the management of this patient is critically ill, and she could die of this very quickly if appropriate management is not deployed rather quickly as well. So I will stop there. Thank you.
Thank you, Dr. Kasim. Dr. Machado, Ann Arbor.
I concur with the prior panelist. Lung contusion with an underlying pneumothorax with a high energy trauma to the chest. This seems to be evolving into acute respiratory failure and even more into acute respiratory distress syndrome. The management should be, as mentioned, chest tube and observe if that responds or the hypoxia is resolved with the chest tube, improving the compliance, but if not, have a low threshold to intubate and start using lung protection ventilation with 60 cc's per kilo and try to limit the plateau pressures to 28. Thank you.
Thank you, Dr. Machado. Dr. Gogler, Lakeland, any comments?
Not much to add on that. This is a young woman who looks like she's physiologically on the brink. She's tachypnic, she's hypoxic. Obviously, she needs her left chest decompressed and likely definitive control of her airway intubation, and she needs to go see Dr. Supra.
Thank you, Dr. Gogler. Dr. Proctor, do you have any comments or questions?
No, ma'am.
Thank you. Dr. Ruiz and Dr. Ochman, I don't think, did you have the chance to hear the case? I'm not sure.
No, sorry, I apologize. I arrived late, so.
Okay, so we'll wait for the next round. Dr. Ruiz?
Same here. I think didn't get to see the case from the beginning, but I can see there that there's definitely pathology going on the left chest. So following the principles of ITLS, secure the airway if that's needed and address the chest pathology. But I'll contribute on the next round.
Okay, perfect, Dr. Ruiz. Thank you. Anyone else, any comments before we go back to Dr. Supa? Dr. Supa, we go back to you.
Okay, thank you, everyone. To give the information to Gabriel and Dr. Hodgman, this is a young lady, 19-year-old female. She had a motorcycle crash with a car 30 minutes prior to transfer to the community hospital. And at first, she looks okay, but 3 hours later, she became more dyspneic, and she had an X-ray like this. And on the CAT scan, they found lots of rib fractures on the left side and lung contusion and pneumothorax and pneumometastasis. So the first hospital, they intubated the patient because she became more hypoxic. And they did also put the left chest tube, which found some gush of air and blood around 600 cc. Hemodynamically, she still had a normal blood pressure, but she was tachycardic. And her first hematocrit was 29%. They did fast exam for the third time, which still was negative. They give her lots of fluid though, in order to maintain the blood pressure. And hematocrit of 29, they gave her 3 units of packed red blood cell and 2 units of FFP. They put her on pressure control ventilation. They had to increase the FiO2 to 100%, and they used the maximum PEEP of 8, but they could not raise the saturation for this patient. So they decided to transfer the patient to our hospital in Bangkok, Thailand. Unfortunately, the lady suffered twice before and during transportation. They did CPR twice and they got return of spontaneous circulation. At my hospital, the King Chulalongkorn Memorial Hospital, she had a third cardiac arrest after she got out of the ambulance. Primary survey, airway, her ET tube was still in place. Her left ICD was draining some air, and we quickly put in the right ICD, right chest tube, which found no additional output. Circulatory wise, her EKG at our hospital was asystole. So we did CPR again. We did closed chest compression for 30 minutes and gave her lots of medications. And this time it took like 30 minutes before we got the return of spontaneous circulation. And she was coma at that time. She was comatose at that time, GCS of 3. After ROSC, we gave her 100% FiO2, but we could not raise the saturation above 70. The systolic blood pressure was okay. We did fast again at our hospital, which was negative. We got a BBG, which showed lots of acidosis and severe hypoxemia, even though this is the venous blood gas. Repeated hematocrit was 40% after 3 units of packed red cell from the first hospital. And she had a lactate of over 20. And this was how the X-ray looked like at our hospital. So I would like to discuss about the causes of respiratory failure in this patient and the further management. Valeria, please moderate for me.
Sure. Dr. Machado and Harvard.
So the primary cause was the hypoxia related to the pulmonary contusion. This patient received 4 liters of crystalloid, and as Dr. Kasim mentioned, pulmonary contusion areas absorb that fluid and then obviously leak into the rest of the lung. So essentially, this was a iatrogenic event related to the excess of crystalloid. The second is that perhaps starting with, as I said, lung protection ventilation, and if you're starting to have increased respiratory or increased hypoxia, then apply what the ARDS net calls the PEEP tables and increase the PEEP to maintain the lung open as this fluid is going to be shifting and then collapsing more and more lung until you end up having hypoxia. So the management, as I mentioned already, is to provide lung protection ventilation with 60 Cs per kilogram, and then apply now the PEEP tables to increase the levels of oxygen in this patient before she goes into hypoxic respiratory arrest. Thank you.
Thank you, Dr. Machado. Lakeland, Dr. Gogler, your comments?
Yeah, I agree with Dr. Machado. It seems like the cause for cardiac arrest has probably been severe hypoxemia. Her X-ray has this diffuse reticular pattern that looks like early ARDS. That could be from her pulmonary contusions and trauma alone. You could have fat embolized syndrome. In addition to that, from her long bone fractures, I think she needs, probably rescue strategies for aggressive mechanical ventilation, increasing the PEEP, maybe switching to APRV or something like that. And if she's not able to correct, we don't have it here yet, but she may be a candidate for ECMO.
Thank you, Dr. Gogler. Dr. Kasim, Portland?
Along with the preventive measures mentioned by Dr. Machado and also the surgeon from Lakeland, I think you have to consider deploying filters if you're going to give blood to this patient, because stored blood contains all kinds of junk in there, and they get filtered out in the lung and add insult to injury here. So keep that in mind as well. I think I would ask an expert respiratory doctor, a pulmonologist, and to come and help me in a case like this. I don't think my knowledge in this is that good enough that I could manage this on my own. And I'm also thinking about deploying ECMO under these circumstances. And so surgically, I don't think I have very much to offer, but I would keep it in my mind that I need to prevent any more iatrogenic problem to this patient who is very close to dying, which is sad. She's only 19 years old. It looks like right from get-go, things didn't go very well for this patient. That's all I have. Thank you.
Thank you, Dr. Kasim. Dr. Antrak, Baghdad?
Yeah, so if I recall the sequence, all the fluids in the blood were given to her after she got hypotensive and hypoxic, if I recall correctly. So, it certainly could have been all the fluid that she got that caused the arrest, or perhaps the precipitating incident, which was very sudden, could have been a massive fat embolization from the femur fracture, where she had a couple of sudden arrests rather than just slow deterioration in her oxygen saturation. So, but regardless, I think, I agree with all the other comments, and she's not really responding well to the use of the ventilator, and probably at a young age and looking so good when she arrived at the first hospital, probably should be placed on ECMO, VV ECMO.
Thank you, Dr. Antrak. Dr. Varone, do you have any comments?
Well, in the old days, we would have treated this with very high levels of PEEP. And and we were the PEEP central of the world. And that's the way we would manage a young trauma patient with a lung contusion and secondary lung injury due to most likely the lung contusion. But nowadays, the treatment has changed, and instead of going high PEEP, these patients would benefit of early ECMO if available. That's really we need to give the lung a break and let it rest while we fix all the other issues, and ECMO will be the next thing to do.
Thank you, Dr. Baron. Dr. Ochman, do you have any comments?
No, I think that Dr. Lakeland kind of summarized everything I was going to say. This is, I would be very concerned about fat embolism. Clearly, the elevated lactate is secondary to the hypoxemia. Just as a side note, some patients in the past with some type of IV contrast, if they weren't metformin, they might develop severe lactic acidosis, but those type of contrast I don't think they're being used anymore. But that's something to keep in the back of our minds. I agree with Dr. Untrak that this appeared to have developed before she was transfused, so unlikely that this is Trally. And this patient, if I have ECMO, I will put this patient on ECMO. If I don't have ECMO, I will consider using APRB. But otherwise, there is not too much more that can be done here. Thank you.
Thank you, Dr. Ochman. Anyone else? Any comments? Dr. Supa, we go back to you.
Just a very short comment on this slide. She's on a PEEP of 8, a FiO2 of 100%. You have way lots of room to continue going up on the PEEP. As guidance, and this is not this disease, but as guidance, I use the ARDS net high PEEP ventilation strategy for these patients. So if you're on a FiO2 of 100%, you should be around on a PEEP of 20 or 22 at this point. Now, the second observation is that it's not straightforward to place this patient on ECMO, as many ECMO programs, at least in the United States, will not consider a patient that has prolonged cardiac arrest as an ECMO candidate. And there's a regional variation and institutional variation, but many institutions in the United States will not consider this as an ECMO candidate. Other options, you can try nitric oxide inhaled to improve your oxygenation, because it seems to be that the issue is more oxygenation than ventilation. And rescue mode ventilations with APRB, as was mentioned. But ECMO would not be a completely straightforward answer everywhere in the United States, and it would change. It will have a variation depending on the policies of every program.
Thank you, Dr. Ruiz. Thank you. Dr. Amayas, would you like to make any comments, or would you like to wait until the next one?
No, you're reading my mind, and I just came on, and it's great to see you there, Supa. But this FiO2 100%, PEEP of 8, SpO2 of 70, just makes me crazy, because I'm semi-ARDSNet and semi-Civetta, and basically this patient should have been on 40 or 50% with rising PEEP until we got to 16 or 18 or 20, at which point some alternate modality like APRV, which we've been very successful with, or proning, which we were using before COVID, but finally COVID got everybody to buy into it. But being on 100% now with only PEEP of 8, there's not much, you're really in a lot of trouble, because this is the sort of patient that codes just from, changing the bed sheets, and there's no knob you can turn to buy a little bit of time. You can't increase the FiO2 while you figure it out, because you're already there. So this is horrifying, but I don't know enough about the case because I just tuned in. So that's just a general principle. And I may be completely off on this patient, but that's my principle.
Thank you, Dr. Amayas. Dr. Supa, we go back to you.
Thank you very much, everyone, for your comments, and Dr. Amayas too. This patient, she was transferred from the community hospital after the motorcycle accident, and she had become dyspneic, and she had cardiac arrest twice before she got to my hospital. And at my hospital, she had her third cardiac arrest, which was successfully treated. But as you can see, she was very severe hypoxic with FiO2 of 100%. So in this patient, we thought about lots of causes for respiratory failure. We thought that she had lung contusion, obviously, from the mechanism of injury and the CT scan and the X-ray. For pneumonitis, because at that time, my country still have a high incidence of COVID pneumonia. So that was the differential diagnosis. She had received lots of volume, like one of the panelists mentioned, and she may have like ARDS or fat embolism syndrome because she had a long bone fracture. She had left femur fracture. She may have like pulmonary embolism on top of these causes, but the CT scan from the community hospital didn't show any large embolism. We tried to increase the PEEP at the emergency department, but she didn't respond to the PEEP. And we, at the same time, after we got the RSC, we called the ECMO team in, and the cardiac surgeon came very quickly and put the VV ECMO for this patient. So we put the VV ECMO at the emergency room. And after that, we could raise the pH and her oxygenation. Other labs show that she had AKI, she had liver injuries, she had some rhabdomyolysis, and her amylase was 400. Maybe she had like a multi-organ involvement from the insult she had. And she had a thrombocytopenia and coagulopathy too. And the chest X-ray after we put in ECMO. And surprisingly, the COVID test came back and it was positive for this patient. So we had no choice but transferring her to the COVID ward. And she was on hypothermia for 24 hours. And in the ICU, we put her on VV ECMO, and we put her on dialysis too, because she had very little urine output. 24 hours later, the formal COVID test came back to be negative. And from the information from the relative, she had a past COVID infection a month ago. So we transfer her back to the surgical ICU on day one after the trauma. And after the hemodialysis and ECMO, her lung looks much better. We could achieve negative fluid balance for several days. And this is her chest X-ray on day 5. She had no consciousness yet after the hypothermia. GCS was low. We did the EEG and it reported to have severe encephalopathy, but no seizure activity. And we could remove the ECMO on day 9, and she started to make a lot more urine, so we discontinued the dialysis too. The CT scan of the brain showed some intraparenchymal hemorrhage, and the neurosurgery was consulted and non-operative management was decided on this patient. Her chest X-ray has been clearing up more and more with time. And finally, on day 15, we could remove the chest tube on the left side. Now she opens her eyes spontaneously, but she doesn't follow commands. The motor response was just a flexion. And she had pneumonia from the sputum exam and from the infiltration on the chest X-ray, and we gave her some antibiotics. We did a DVT screening on the patient and it was negative. She could tolerate feeding well, So we feed her via an NG tube. And we could go down on the respirator. On day 18, she was stable enough to be transferred to the OR for tracheostomy and for fixation of the left leg. And now it's around a month after the injury. She was transferred to the trauma ward and she recovered from all the organ failure, but her consciousness is still not very good. I hope that with time she will become more alert and recover from neurologic insult. So this is everything I have about this patient.
Thank you, doctor.
Sorry.
Super. Do you think the decreasement status is related to COVID, that a lot of patients after COVID present to this confusion or decreasement status neurologic problems for a while? Or you think it's related to hypoxia?
Because the first COVID test came back to be positive, we thought about COVID pneumonia too. But as a part of the causes of the respiratory failure, not the main cause, I guess. But after we obtained more history from the relative, she had past COVID infection a month ago. So the formal test came back to be negative. The ID guys in my hospital said that this is not an acute COVID pneumonia. It was like past infection. But I was wondering whether or not the COVID infection may prime her lung to be more prone to inflammation or ARDS. That I'm not sure of. And I did some review about the fat embolism syndrome. And because this is quite rare, and I'm not quite sure whether or not I have encountered this syndrome, because usually there are lots of differential diagnoses in the patient with respiratory failure after trauma. But like Dr. Kasim mentioned earlier, fat embolism syndrome is one of the differential diagnoses when the patient has long bone fracture. So clinical signs usually include petechial hemorrhage and altered mental status and respiratory failure within a few hours. And the pathophysiology from for multi-organ failure, there are two hypotheses. Number one is mechanical obstruction of the microcirculation. And number two is biochemical hypothesis. They said that free fatty acid in the blood may trigger inflammation. The diagnosis usually done by clinical criteria, and the treatment was mainly supportive. The best prevention for this syndrome is to do the early fixation of the fracture. So after the fractures, the patient may have a translocation of fat into the circulation, and the fat from the bone marrow may occlude the small blood vessel in several organs, causing organ dysfunction. Or the free fatty acid in the blood may trigger inflammatory response, and the patient may have like sepsis-like or SIRS-like syndrome. And main organ involvement usually are brain and kidney and respiration. This is the mostly used criteria for diagnosis of the fat embolism syndrome. For this patient, she had a respiratory insufficiency. She has cerebral involvement, which I'm not quite sure whether this is from post-cardiac arrest or from the fat embolism. But she had no petechial rash. Minor criteria she had, she was tachycardic, and she had no retinal changes. We called the ophthalmologist to check on that already. She had some increased bilirubin, and she had acute renal failure and thrombocytopenia. So by using the clinical criteria, she may have a fat embolism syndrome. But other causes like lung contusion and volume overload may also be the causes of respiratory failure in this patient. And that's it for this patient. I'd like to hear the final comment from you guys.
This is Albert Barron. You know, as somebody who takes gas anesthesia for orthopedic trauma for, I don't know, more than 30 years, I have never, and I have dealt with fat embolism multiple times, I've never seen this degree of hypoxemia from fat embolism, but I have seen it from lung contusion. This patient had multiple rib fractures. She may have had COVID or not, but I think lung contusion will be much higher in my diagnosis than fat embolism syndrome in this case. As you know, most patients that have trauma have fat in the circulation. There are very few develop this syndrome, but this degree hypoxemia, I've never seen. I would go more for the multiple rib fractures or lung contusion as the primary. Obviously, she had other things that explains that. And obviously, the fact that she had a couple of cardiac arrests would relate to the encephalopathy that you would see after this. Nick, what do you think?
I mean, we've seen hypoxemia, but maybe the combination of the contusions, the fat embolus. I don't know. I don't get surprised anymore. I just discovered I learned something I didn't know. Could be. Did she have petechiae?
No.
Did she have petechiae?
Pardon, Dr. Damayas.
Did she have petechiae?
No, she didn't have the pedicure.
We've also just recently discovered that 30% of our PEs in a recent thing are 30% of our PEs are present on admission. We looked at PEs and they're within the first 5 days, and we find several of them on the first CAT scan, like the trauma pan scan has, it could be a primary pulmonary thrombus, but for whatever reason it's clot in the lung. So maybe she had a combination of everything. So I don't know, but it's a great case, Supa, great save.
Thank you,
Thank you.
Dr. Supa, I also want to make a comment about the hypothermia. The studies that have been panning out regarding the use of hypothermia in out-of-hospital cardiac arrest have shown that it's not really the hypothermia, but the prevention of hyperthermia. Fever fries the brain. So the reason those studies show improved outcome was because hyperthermia was prevented. But you can be targeted to normal thermia is appropriate too. The problem that you have with hypothermia is then you have to wait after that for a few days to figure out if the patient's going to wake up or not. So my thing is, I think we should be targeting normal thermia at all costs, but I'm not sure that anybody has shown hypothermia as being of benefit.
Thank you, Dr. Varon. In this case, we kept the target temperature at 35, not very, very low, but your point is very well taken. Thank you very much.
Dr. Antrak, Baghdad.
Yeah, so great case as usual from Dr. Supa, and really a terrific save. How far out is the patient now? Still 18 days, or is she starting to wake up? Or just 18 days and not fully awake yet, but it looks like she's making progress. And I learned a lot from listening to the expert intensivist. And I think in this case, what the exact cause was, it's an interesting discussion about the pathophysiology, but it probably doesn't change the management much at all. And but certainly a very unusual case as it was billed, and very instructive, very well taken care of by Dr. Supa and his team. And thanks for presenting it. And I hope she continues to get back to normal, to wake up fully and recover.
Thank you, Dr. Antrak. Dr. Kasim, Portland.
Long time ago, when I was a fellow at the University of British Columbia, I spent a year in the thrombosis lab, and then I was given an assignment to study fat embolism at that time. And it was my duty to go and draw blood on patients who came in with long bone fractures and have it spin it down and look at it and study it. And the conclusion I came to at that time was that this syndrome, this fat hemorrhage syndrome is ubiquitous. It can happen without petechiae, with petechiae in the retinal area, if it is going to happen at all. And it's a hidden syndrome. You have to look for it, and you have to document it by doing appropriate tests, which is getting the blood, spinning it down, and looking at it to see how much fat is in there, etc. And one of the things that I learned at that time was that if you add heparin to the fat in the test tube in vivo, the fat disappeared. And then we were not able to show whether that is applicable in clinical examination because we didn't go any further than that. But this patient could have had the syndrome of fat like Dr. Suppa mentioned. And that may be an additional thing to the fluid overload and other mismanagement of the patient when she came to the hospital, in the community hospital. They didn't even do a chest x-ray to look for something like this. So it is worth getting up at 5 in the morning to listen to Dr. Suppa again, and of course, having the participation of the professor is a plus.
Thank you, Dr. Kasim. Dr. Machado, Michigan.
Thank you, Dr. Suppa, for bringing this very interesting case, and as well as thank you for all the panelists for bringing their insight and being part of the ECMO group here at Michigan. Just to want to clarify about candidacy for ECMO. First of all, we have to understand that ECMO is a supportive treatment. It does not cure pulmonary contusion, does not cure COVID ARDS. And unless this patient has a chance of recovery and salvage, that will be what we would be looking into candidacy for ECMO. And I think she had very well indeed indicators that she could recover if we were able to provide support. So in this case, I would not hesitate to give her ECMO. The other thing is in regards to the cerebral hemorrhage. This could have been related to the anticoagulation that you have to provide during ECMO. However, you can run ECMO without heparin. That is important to know that with these circuits, especially if you're running at high flow rates, you can use heparinless circuit with the risk that it can clot the circuit, and then you have to replace the oxygenator. And then finally, it's worth mentioning that you still have to apply the same principles of the ARDS network. So meaning that a lung protection ventilation, but now once you're on ECMO, then you can rest the lung and let the lung heal so that you can have that recovery as we've seen in the evolution of this patient. Once again, thank you, Dr. Suppa, for bringing this patient. And I'm going to share our algorithm for ECMO in a short bit. If you allow me, Valeria, I'm just printing out the PDF.
Of course, doctor. Thank you, Dr. Machado. Dr. Ochman, Boston?
No, I have really nothing to add. This is a very unfortunate case. Only thing is adding to what Dr. Barón said before, there was a paper in the New England Journal of Medicine this year where they compared normothermia versus hypothermia in pre-hospital cardiac arrest, and they didn't find any difference in the 6 months mortality between the two groups. So we have a protocol for hypothermia here in the hospital. We still kind of use it, but maybe we should stop using it. No, unfortunately, it's a very bad case. Thank you. No bad
Thank
case
you.
in terms of management, in terms of the outcome, because you did everything perfect. This patient had a devastating head injury that you cannot fix.
Thank you, Dr. Ochman. Dr. Gogler from Lakeland.
Nothing to add as far as the management of this patient. Thank you, Dr. Supa, for chairing this. As a center who is looking at starting an ECMO program, it's a fantastic case and very inspiring, and congratulations on your success. As far as the hypothermia thing, just to kind of add, what we're doing here is we're doing mostly targeted normothermia after traumatic cardiac arrest, trying to maintain that temperature around 36 degrees. But man, it's really great to see everybody on here this morning, and hopefully Lakeland can continue to participate in these. Thanks again.
Thank you, Dr. Rogler, and we look forward for seeing you again at the session. Dr. Martos, would you like to make final comments?
Yes, I'd like to say thank you very much, Super, for another great case. It's always nice to see you in the screen, my friend. Missing you. I hope next year the Pan America Congress in São Paulo you could be there. And if you can be there, I'd like to invite you to be part of one of the North versus South or South versus Europe or Middle East or rest of the world sessions, okay? It would be very nice to have you there. It's very nice to see Drew here. How are you? Last time I saw you was at the Rio Games, Olympic Games. Good to see you.
Been far too long.
Exactly.
I think Dr. Machado was going to share his PDF of the algorithm in ECMO. If you can share it on the screen, it will be appreciated.
Yeah, Dr. Machado,
Definitely.
please.
Dr. Machado, you can share your
Maybe you can just drop it on the chat. That way we can pick up the file.
Yeah, I'm trying to upload it to the chat. Are you able to see the screen right now?
Yes, the screen, yes.
So this is just a brief overview of just standard ARDS net ventilator management. So we always start with basic lung protection ventilation, and then start doing the salvage ventilator strategies. Dr. Namias mentioned APRV. Those are very good strategies to maintain the lung open. We also attempt to improve the ventilator dysynchrony by paralyzing the patient if that's necessary, and then start going through algorithms of that if we continue having hypoxia. Dr. Ruiz had mentioned nitric oxide. There are other agents that can help with the VQ mismatch, such as prostaglandin analogs. So not all hospitals have nitric oxide. And then it's important that to bring the good lung down. So in this case, the right lung was the good lung. You can improve the VQ mismatch by putting counterintuitively the good lung down, which will allow by gravity a better perfusion profile of the good lung. And then finally, ECMO would be our last strategy as for salvage. I'll try to again print this out and share it in the chat in a moment. Thank you.
Thank you, Dr.
Thank you.
Machado. You can also send it to me and I can distribute by email, Dr. Machado, if you can.
How about that? I'll do that. That sounds to be the easiest way.
Sure.
And Dr. Machado, we're going to launch today the new Pan American Society platform. It's called Virtual Education Center. So we have multiple areas, multiple forums. And for sure, it will be very nice you can share your algorithm in one of the forums over there. The idea is that you're going to have a lot of interaction between the members and between everybody, and post case have other people opinions. So it's going to be a nice way to interact in the meantime when they don't have the Congress, etc. So the website, the platform will launch today. and I'm going to receive an invitation. I'm going to post some videos showing a little bit how the platform work. And next week, you're going to have 3 days of virtual academic activities from the Pan America. We're not going to have a Congress this year. The Congress was postponed for next year in São Paulo, July. But Tuesday, Wednesday, and Thursday next week, we're going to have 3 hours in the evening from 6 to 9 Miami time of activities. Tuesday, we're going to have the paper competition. Wednesday, we're going to have lectures about pre-hospital care and nursing care. And Thursday, we're going to have the traditional North versus South. 3 cases being presented, one by Dr. Namayas, one by Dr. Francisco Tele from Brazil, another one from Dr. Carlos Ordonez from Colombia. Looking forward to see everybody next week. And Valeria, you have a Monday at noon, we're going to have another good case to be presented. Thank you all.
Yes, yes, from Ryder. Next week is from Ryder. Thank you.
Okay.
Thank you, everyone.
Super good seeing you. I saw that Thailand is opening again for tourists, so COVID is better. Looking forward to either to visit you or to have you in Brazil next year, okay?
Thank you very much, Dr. Matos.
Take care, guys. Bye.